And so, no, introduce the gallbladder carcinoma. Gallbladder carcinoma is associated with the sperm in the over 90% of patients. And there is female to male ratios of 3 to 1. Why? I didn't know, because we have reached some conference. I have not found causes. Why is the female to male ratio is 3 to 1? And maybe hormone. Yes.
Excuse me, Doctor. A lot of Chinese gallstones is very common in the Chinese population.
Yes.
And what about male to female ratio? Is it more in females than in males, or more in males?
Yes, in Chinese also female is more common gallbladder. But a few patients was diagnosed from the surgery. Gallbladder carcinoma. This we can show. This is gallbladder. This gallbladder carcinoma. This is gallbladder carcinoma. This is ultrasonography. This is CT all show the gallbladder carcinoma. This gallbladder, we can find the occupation in here, but this invasive gallbladder fundus into liver. And this CT scan showed this stone and have carcinoma, this occupation in here, is tending the outside of fundus, the side of it. We can find another signs. This posterior head of pancreas have a very large lymph node. This may be metastasis. So this is a very advanced gallbladder carcinoma. Yes. But gallbladder carcinoma have a TNN classification. T0 is no evidence of primary tumor. And T is the carcinoma in situ, right? In situ, right? And T1 is the T1A and T1B. Tumor invasion is the laminar propria, and T1B tumor invades the muscle levels. T2 tumor invades the muscular connection tissues. T3 tumor is a perforation to the cellular cells and to invade the liver and another organs. T2 is the tumor invade main port vein or hepatic artery, invented multiple irregular hepatic structure. So it's the TNM classification is this is about T. And N, regional lymph node, Non-X, regional lymph node cannot be associated. Non-1, non-regional lymph node metastasis. N1 is the regional lymph node metastasis. And distant metastasis. NX, distant metastasis cannot be associated. And non-cellular, no distant metastasis. And M1 distant metastasis. So this CT scan, can you tell me TN class is which stage?
TN4.
Why? T. First we have T. This is occupation.
T1 and
Have invent liver, right? Invent liver is T3. T3, right? T3, yes.
Node also.
T3. And have any lymph node? No. No. And no.
Why is this T3?
Pardon?
Why is this T3?
T3.
Why?
T3 because invent liver. Invent
Lamina
liver.
propria.
Okay. If tumor invent the liver, we get T3. Okay. And we can find no metastasis. So the T3, N0, M0, M0. Right, okay. Right. Number how to treat? Yes, operation, right. Radical surgery. Radical surgery for operation. Including segment liver dissection or biological dissection and intensive lymphadenopathy. Right. For broken impatient with the unresected tumor and independent radiation therapy may provide the palliative benefit.
Laparoscopic
And
management
this
of
we have a video
acute
to
colitis presents a
laparoscopic
certain
for
effect,
acute scientists.
and most theories report a high conversion rate, up to 40%, even in expert hands. Here, an acute inflammatory mass is separated from the inflamed gallbladder using simple blunt dissections, indicating a short history of a few days before denser adhesions have developed. The gallbladder wall may be friable and easily damaged by the blunt graspers, with leakage of purulent fluid. A second problem is the lack of mobility of the gallbladder and surrounding tissue due to edema, which impedes the surgeon in visualizing Callow's triangle. With patient dissection, using the blunt suction irrigation, it is usually possible to identify the important structures of the cystic duct and artery. Although identification of the common bile duct itself may be impossible, the cystic artery is found but proves to be friable. Further blunt dissection divides the peritoneum posterior to the cystic duct, and this allows a plane to be developed between the duct and gallbladder and completely opened. The gallbladder is pulled away from the porta hepatis with the suction, whilst the cystic duct is grasped. The duct is too thick for simple clipping, but careful dissection thins the tissue. Before clipping and division of the cystic duct, the surgeon follows the wall of the gallbladder into the gallbladder bed to be sure that the structure he believes to be the cystic duct is not actually the common bile duct being distorted by traction. This is one cause of accidental division of the common bile duct. The cystic duct is clipped and divided using large liga clips. If the cystic duct is too thick, it can be divided with the end of a GIA stapling gun or ligated. If the gallbladder wall has been opened, then gallstones might be released and should be removed. The gallbladder is separated from the gallbladder bed using a combination of blunt and hook diaphragm dissection. In this second case, an inflammatory mass is easily separated from the gallbladder. The Weck grasper has been positioned on the gallbladder fundus, but it is placed lower down to increase traction, pulling Hartmann's pouch away from the common bile duct. Blunt suction dissection is used initially. This proves to be an empyema, and pus is seen to be leaking from the fundus, where the grasper has again caused perforation of the friable gallbladder wall. The structures in Callow's triangle begin to emerge from
老师听起。
是你在开的。这个
可以按这个。
The inflammatory tissues. The cystic artery is seen and is clipped at this early stage in case accidental damage results in bleeding. Attention is returned to the cystic duct and an attempt is made to open a plane between the duct and the gallbladder. In this case, the tissue is too thick and the suction instrument is replaced with a slightly sharper Vitelline forceps, which is passed between the duct and the gallbladder, allowing this plane to be developed further. Care needs to be taken with the Vitelline forceps, which is sufficiently sharp to injure the biliary tree, particularly in the presence of acute inflammation. Once satisfied that the cystic duct has been identified, it can be clipped and divided. Once again, large nigger clips are used for this thickened duct. The cystic artery, previously clipped, is now divided with diathermy. The gallbladder is separated from the liver using diathermy. The plane can be difficult to identify, and the surgeon has accidentally perforated the gallbladder wall. Once the gallbladder is separated, it is removed through the epigastric port, often requiring a retrieval bag and slight extension of the incision. Extensive saline lavage is performed to remove any blood clot and spillage from the gallbladder. A ready back drain is left in the subhepatic space and removed on the first post-operative day.
So sometimes AOC is very difficult for treating acute cholecystectomy and for acute cholecystitis, or sometimes these patients have Meniere syndrome. It's very difficult. You can see this video because the patient have more pills in the gallbladder, and the gallbladder wall is very thin, so it's very difficult. But if one patient have only gallbladder polyps, if we do cholecystectomy, it's very easy. It's very easy. So next we try to present this of the viaduct.
Also, the fluid which was coming out of the duct, it will not cause any harm, no complication later on, because it was going inside the abdomen.
Yes.
So, no complication later on?
No. If you would do it, but no complication. No. Pardon? Pardon?
The fluid, the pus was going into the abdomen. Inside the abdomen, it was leaking, right? It was not, there was no suction at that time. It was leaking inside the abdomen.
When you section. Every section. If you have some post to abdomen, we will use section, and don't worry.
After finishing,
After finishing, we will bring water, washing, and section. Yes.
Don't worry.
Again and again. Have a very clear, so we open close. Yes.
不要着急。
So we present this all of the viaduct. Okay. If you have a question, okay, interrupt me. Okay. About this sort of viaduct, we introduce the polyfluid for this LSC and choledocholysis, hepatolysis, and choledochocyst, and cholangiocarcinoma. And about pancreatic and ambular tumor, we will another teacher we will present in the pancreatic disease. Okay. Both we introduced AOSC. What's AOSC? AOSC is acute obstructive suppurative cholangiocarcinoma. A, acute. B, obstructive. C, suppurative. C, C and cholangiocarcinoma. This is yes, cholangitis, right? Cholangitis, right? This is a very important syndrome. This is very important because all is emerging disease carry the higher mortality. All causes is common of the child failure is stone or tumor and with infection, with serious infection. Right? Complete obstruction and the cellular infection, right? May result in septicemia and septic shock, or causes NSOF, multiple system organ failure. So, about LSC have a clinical finding. First is abrupt onset of the pain in upper quadrant, and second, chill, high fever, menosis or vomiting, and jaundice. Sometimes may shock and acute renal failure and ARDS. So this is NOSF. Why? So this is charcoal child. Do you know charcoal child? Yes, the first introduced maybe. Child side 1, PAM. Second, fever. And third, jaundice. This patient have upper quadrant pain and high fever and jaundice means charcoal child. This is very important syndrome or clinical finding for LSC. If we have a charcoal child, we have pay attention to this patient have a very serious infection. So this is very important treatment. First, we collect the fluid and acid-base balance. Second, systematic administration of the antibiotics. And then anti-sugar treatment. And drain of the biliary tract, EICP or PTCD, and emergency. Sometimes we chose emergency operation. This choledocholitis, CA ultrasonography showed this gallbladder should have a stone. This is CBD stone. Show have shredded. Because the CBD stone have the child here, so that, and with the infection can maybe causes LSC. This another NRCP showed have a stone in here. Okay, you presented choledocholitis. Okay, we have okay, 5 minutes. Okay, 5 minutes. Okay. We presented choledocholitis. We very Thank you. My assistant, my teacher assistant, 我这个都跟着会。This slide can help you do more work for you. Now we introduce the work of the system. Choledochore system is the dilation of the exudative hepatic viaduct, and it's a ratio about female to male, also 4:1. Just as like gold bladder, and gold stone, and gold black stone. Yes.
男的比较健康。
Right. And majority are neurodiagnostic in children and classified into 5 types. 5 types. All choledochore system was associated with the various relations. Type 1. Type 1 we can see this is no, not last week. Okay. Type 1 system was the physical dilation of exudative hepatic viaduct, incident about 7-9%. This is the choledochore system. And type 2. Type 2 is the place diverticular incident about 3%. So only this is a choledochore system. Yes. And type 3 choledochore cellular of intraduodenal common viaduct dilation. This is only located this. And type 4 exudative and intrahepatic cyst incident about 13%. And type A intrahepatic dilatation incident about 4%. This is all named as a colorless disease. Choledochore cyst. This is CT scan showed. This is a choledochore cyst located distal common viaduct. This is common viaduct, and this is showed. NRCP showed. This is type 1. Viaduct and introduce viaduct cancer. Viaduct cancer, we only introduce the cholangiocarcinoma. And another disease, pancreatic and ampular tumor, we will present by another teacher in pancreatic disease. About cholangiocarcinoma, this is a very important disease. Most of the common and the hepatic duct bifurcation were all named classical tumor. And all presented with the, about the clinical finding, all present with jaundice. And the clinical present all includes jaundice, pruritus, fever, mild abdominal pain, and the fatigue. Surgery resection often a chance for the long-term disease-free survival.